good Saturday morning to everyone. And I hope that you're having an amazing 4th of July weekend, a long weekend. So we clap for that. Welcome again to another workshop on lung cancer. It's a community conversation about lung cancer. Our theme here is if you have lungs, you can get lung cancer. But the good news, I don't want to just lean on the bad news. The good news is that if it can be detected early, then it can be cured. You can live a productive and happy life. This is our time to talk about the issues that are affecting not only you, but your community, the state, the country, and even the world with this valuable information. We have some amazing physicians. We have some amazing nurses. We have some amazing clinicians that are going to be giving us resources to meet the need of you and your family. And before we get started with the workshop, do you mind going with me in a word of prayer? Will you bow right where you are? Doesn't matter if you're in the kitchen or you're standing out somewhere. Let's bow before God now and trust that He is going to not only hear us, but answer our prayer. Will you bow with me? Father, we're so grateful to you today for this moment. You have called us here. Every participant, every clinician, every presenter. Lord, we ask now that you would move upon this gathering and cause our minds to think like you, cause the words that come out of our mouths to be productive and what you would have us to say in this hour. God, we know that there are many of our brothers and sisters around the world that are struggling through the journey of lung cancer. Let us be a benefit to them. Let this program be a benefit to them. And in all things, God, you get the glory. It's in the precious and mighty name of Jesus Christ we do pray and ask it all. And those that agree, let's say amen and amen. We are again excited. I am so excited that you took out of your holiday weekend to be with us for a few moments. And I want you to know that we designed this program just for you or with you in mind. Again, as I said before, this is a community conversation. It's about educating the community on the risk, the challenges, the successes of lung cancer and its related diseases. I'd like to thank all of our partners in this effort. I'd like to thank Amgen. I'd like to thank Morehouse School of Medicine. I'd love to thank Grady Hospital System and our amazing partnership with Hill Collaborative and the Impact Church family, not just here in Atlanta, but those of you that are watching around the world. I want to shout out Jill from Ottawa, Canada, who called me last week and said that she has been going through her own personal journey and has found this workshop to be an amazing resource. Jill, thank you for being on with us all the way up north there in Ottawa, Canada. Get ready for an amazing celebration of information and conversation between us and you. And so without any further delay, I want you all to sit back, relax, and get ready for information that is going to change lives. I know that my voice sounds excited because I am. I am because the thing that I look forward to most is serving God and serving God's people. And this conversation is to educate the faith community about lung cancer, as I said, and its related diseases. And so without further ado, I'm going to bring now to the screen Dr. Fanal, who is an expert in, he's a neurologist and an expert in lung cancer and its related diseases. And I know he's told me privately that we've seen some successes, and we're going to start with his panel. But I want you to stay throughout this workshop series because there are going to be many giveaways. There's going to be many opportunities for you to share. And please list your comments in the comment section as we go along, because we're going to have a Q&A session at the end of this, and it's going to be great. We're going to answer your questions, and we're going to give more information as we go. Good to see you, Dr. Eric. Come on in.
Nice seeing you, sir. Thank you. Thank you.
Yes, thank you for joining us. I turn
And
it over to you.
it's good to know we went international.
Yes, absolutely. Absolutely. The word is getting around.
Oh, yes. Oh, yes. Well, thank you. Yes, we can get started. I know for those who've been a part of the earlier discussions, we've been talking about why lung cancer and being aware of lung cancer is so important in our community, especially as there's, defined and clear disparities, especially with African American population. But now we need to start thinking about, okay, what can we do about it? Okay, so how do we detect it early? What does screening involved? And how do we get through making some of these decisions as to whether or not to go through screening or if we're even candidates for it? So, next slide. Okay. Got it. So first thing to think about is what exactly is screening? You hear it a lot with breast cancer, with prostate, with colon cancer. And the main goal of screening is that you're checking for cancer before there's any symptoms or signs. It's especially important with lung cancer because for those patients that have symptoms of lung cancer, about 75% of them have late stage disease. Lung cancer can develop silently as just little spots or little nodules in the lung. And it's not until they get larger and they start involving areas that you can detect it that you'll actually be able to know that it's there by symptoms. So the best way is try to detect it early before there's any symptoms. So recently there's, I'd say about the past 5-6 years, we've been employing a screening technique using CAT scans or low dose computed tomography CTs. Okay. And so what that is, it's a CAT scan, but it's not using high dose radiation for that. And they're looking through, and if you look at the image over to the right, that is a low dose CT scan. And on the right, on the left hand side there, in the spot, you'll see a little bitty spot there. And that's an early cancer that was detected just by this person having a yearly CAT scan. It only takes about 15 minutes to do. And that's from getting changed, getting gowned, getting the scan and coming out. But it's something, that process of a yearly low dose CT scan has actually been shown to improve the likelihood of people dying from cancer. There was a national lung cancer screening trial that was done a few years ago, and they used low dose CT scans. And they found that those patients that had a CT scan yearly for about 3 years had a 20% chance lower chance of dying from lung cancer than those that were just screened with chest x-ray or had nothing at all. And there was another study, it's the Nelson trial. And you don't need to remember these names, it's remember the numbers though. You get this CT scan yearly and you have a 20% less chance of dying of lung cancer. And the Nelson trial showed that when they did screen people, that it actually got better when they had an organized fashion of it. And the risk of dying lung cancer decreased by 25% for those that received the screening. So it may not be the one thing that everybody wants to jump on board and recognize a risk. And I don't want to screen because what if they find something? But that's exactly what we want to do. We want to find it before there's symptoms, before it's late stage, and be able to go ahead and get you treated because you get a 20 to 25% chance of living through lung cancer. Next slide. Can we advance the next slide? Seem to have lost. Next slide. You can get next slide. Are we frozen? There we go. Okay, good. So who should be screened and how do you know if you're somebody that meets the criteria to get screened? Well, the United States Preventive Service Task Force, and these are people that look together and they put forth the guidelines on who to get screened for different disease processes. They suggest that you get a yearly low-dose CT screening if you are between the ages of 50 to 80 years old, if you have a 20 pack year smoking history. So what does that mean? 20 pack years. So the healthcare providers have a way of calculating or getting a rough estimate of how much you smoked. And that's basically how long you have smoked throughout your life and how many packs you've smoked on average per day. Now, it may be that you may have cut down or whatever else, but they're trying to get an average. So, for example, if I have smoked 1 pack a day for 30 years, then I have a 30-pack year smoking history. If I've smoked 2 packs a day for 15 years, then I have a 30-pack year smoking history. But if you fall within that 20-pack year smoking history or more, and you're age 50 to 80, then you qualify. And the other criteria is that you're either currently still smoking or you have quit within the past 15 years. So if you have quit 18 years ago, then you really wouldn't qualify for it. But if you have quit 2 years ago, then you still and you meet the other criteria, then you would qualify for getting an annual CT scan. Next slide. And so this is what it looks like, and this is how it pans out to the lives that are saved and not saved. So first, let's focus on the image or the picture on the right-hand side. So if you took, and this is the data that they got from the studies, if you took 1,000 smokers, and this was between ages of 55 and 74, that were not screened with CAT scans, they found that 21 of those people would have died from lung cancer over a 6.5-year period. The difference is you take the same smokers, same age group that were screened, and this is when they just had a screen once every 3 years, right? That 18 would die from lung cancer. And so you say, okay, 21 to 18, not a big number, right? Because it's only a 3 difference. But the difference there is the percentage wise, because you're getting to about 15% people improvement or 15% less people dying from lung cancer. Next slide. So focus a little bit closer on that. That's a big thing because you have 3 more people per 1,000 lives saved, right? And if you're one of those 3 people, it does make a difference. Next slide. Okay. So then how do we make these decisions, right? Because it gets a little tricky, and I got to go get a CT scan every year, and it's, you're still trying to quit smoking, and it's a little bit scary. And what if they find something? And so how do you make the shared decision-making process? And the best thing to do is have a discussion with your healthcare provider. Reach out and talk with them. And so that you can weigh what are the risks of being screened versus what are some of the benefits. And so we look at some of the benefits, and they're just as I mentioned, that the annual screening with low-dose CT scans does reduce the likelihood of dying from lung cancer somewhere between 16 to 20% if you take the average of the 2 studies that show the biggest benefit. Next click. However, anytime you're doing one thing in medicine, there's always risk and there's always benefits. So what are the potential harms or the risk of being screened? Well, one is you have to have that CAT scan, and you're exposed to low dose radiation with a CAT scan. Now, that being said, it is a low dose. The technology nowadays gives very low dose. It's not much more than if you're walking through the scanner at the airport. But that's once a year. The other risk is you might have false results. And what does a false result mean? So we're looking for, like you saw in that scan, the little bitty nodule that's sitting down there. And you might see a nodule, or they might see something that looks kind of suspicious. Well, just because there's something on there doesn't always mean that it's cancer, because the lung gets everything that we breathe in and out. You might have inflammation, you might have a little infection, you might just have scarring from something that happened a long time ago. So the CAT scan is only a picture. But what that means is, you might have to have a biopsy or something else to confirm that it's there. That being said, it doesn't necessarily mean that it's cancer. And sometimes it's good to find out that whatever is there isn't cancer. It takes that pressure and that relief off from the patient. Next slide. Okay. So what are the likelihoods of finding something that's abnormal, that's a false alarm, that's a false positive there? Well, of those same 1,000 smokers that were screened for, every 3 years, 120 of them had a false alarm. They did not have lung cancer, but there was something on the CT scan. So you have to say, is that really a harm to find something, but it's not cancer? I think it's actually a little relief that you looked, you found something, it wasn't cancer, and you keep moving on. You may have had to have a biopsy, you may have to have a follow-up CT scan, but at least it's excluding that. Next slide. Okay. So shared decision making. These are the discussions you have with your healthcare provider. I have this discussion with patients all the time. The benefits of getting screened. Well, you reduce the chance of dying from lung cancer significantly. And you're finding a lot of times you can find other problems that might be treated earlier. For example, that spot might be an infection, right? Which antibiotics could take care of and cure up pretty quickly. But the potential harms, yes, the exposure to radiation, it's a very low dose. Like I said, it's less than if you're walking through the scanner at the airport. And so if you're taking 2 or 3 flights a year and you're going there and you're coming back, you have to get scanned each time, you're getting 4 to 6 scans like that a year. So it's less than that. The false alarms may have extra tests and extra tests or biopsies. So be it, that's fine. Because you're excluding cancer. You're taking that off the table if you find that it's something else. Okay. And then you might be treated for a cancer that might not even cause you any harm. And that's a really hard one to determine, because we know what we have found since we've started the whole screening process is that we find lung cancers early. Some lung cancers may resolve by themselves. Your body may have the ability to handle it and take care of it and get rid of it, while others will continue to spread. But when we find it, it's a risk for us to sit back and take the chance that it's just going to go away by itself. So some people might have to have treatment or going to go treatment. We don't know if it would have resolved by itself or not. The thing is, there is a risk of waiting. And the risk of waiting is if it is one that doesn't resolve, then it may potentially spread and cause problems later. Next slide. I think that's it. Yes. So, yes. Oh, finally, yes. Along with your discussions with your doctors and the shared decision making as whether or not to go through this, is to also discuss stopping the risk factors for developing lung cancer. And that biggest one is smoking. And keeping in mind that if you stop smoking and you can get screened, is once you start the whole screening process and you stop smoking, once you start the screening process, you only have to go through this for about 15 years. Because if you get beyond 15 years, you don't need to get screened anymore. So you keep that in mind, that it's essential that you work on stopping the risk factor, the biggest risk factor for lung cancer screening, which is smoking. And that if your CT scan does not find lung cancer, that's not a reason to continue smoking. We still have to stop that risk, because the sooner you stop smoking, the sooner you can stop getting those yearly CT scans. And with that, I'll take a break so I don't tie up too much time. We can take questions if we need or move on to the next panelist. Thank you.
I am going to introduce myself first, and then I'll introduce our panel. So I'm Dr. Christina Austin-Valaire, and I am a psycho-oncology coordinator at Northside Hospital. I've been in the field of oncology for over 25 years. I've worked both inpatient and outpatient, worked with a lot of patients and families, a very rewarding area of practice. I want to give you a moment each to just introduce yourself, say a little bit more about your specialties, and then we'll get started with this discussion this morning. So Dana, would you tell the group that's here today a little bit about yourself?
Hi, everyone. I'm Dana. I'm a nurse practitioner. I work at Grady Health System. I've actually been the lung screening coordinator at Grady for about 5 years, almost 5 years. My background is actually in surgical oncology. I've been a surgical oncology nurse for majority of my career before I went to nurse practitioner school. So usually I was working in the actually after diagnosis. So this is the first time working on the pre-screening side. So I'm actually excited and encouraging patients to, go ahead and get screened.
Mm-hmm.
But I love the work that we're doing.
Absolutely. Okay, thank you so much for that. Benet, would you tell us a little bit about yourself?
Hello, everyone. I'm Bené Thompson. I actually have a background in radiology, and I'm the lung screening navigator for St. Joseph Candler Health System, but I work mainly in the Nancy N. and J.C. Lewis Research and Pavilion. I'm really glad to be on this panel to share with you guys how lung screening can help save lives, and I really enjoy my role as a lung screening navigator.
Awesome. Thank you both. So, as we know, lung cancer is curable if detected early, right? So, early detection, seeking care, and finding the right provider and getting support through our nurse navigators is critical to a successful journey with this disease. And so, I have the first question I want to ask is going to be to Bené. How can someone get a lung screening if they do not have insurance or a job?
Okay. So in Savannah with the St. Joseph Candler Healthcare System, we have what we call medical homes. And at those medical homes, we have one St. Mary's that's housed in Savannah. And then we also have the Good Samaritan Clinic that's housed in Garden City. And with those medical homes, we have physicians, nurse practitioners, nurses, and medical assistants that see indigent patients or patients who do not have insurance. At that screening or at that meeting or initial meeting, it's kind of like family practice where they will do all of the screening, all of the checkups, routine medications, and things like that. And that
Mm,
physician or PA or nurse practitioner can order the patient who is uninsured a lung screening when they visit the medical home. So that's how they can obtain a screening if they are uninsured or underinsured, or if they don't have a primary care physician.
that's awesome. So, if I get lung cancer, I get a lung screening and lung cancer is detected, are there resources to help me pay for treatment? Dana.
Yes, definitely. At Grady, we have a patient assistance program. So it
Mhm,
actually helps even before diagnosis, getting patients in for the primary care, get them screened. And then
mhm.
also on the diagnosis end, it continues. And then also there are also cancer state aid that also helps support patients that they can apply for after diagnosed. And we have social workers that help them through that process.
Wonderful. I think that's such wonderful information, and I'm so grateful that we're able to get that out today. So, Dana, how will I provide for my family financially if lung cancer is found and I'm unable to work?
The good thing is we have a lot of social workers, a lot of people that actually donate to different programs at Grady. So in
Mhm,
addition to things like clothes or goods that we always receive from the community resources, we also have a lot of grants that are accessible through our outreach. We do have a
mhm,
Grady Foundation that they apply to different grants, and a
mhm.
lot of them, some are allocated to the lung program. So
Great.
patients are aware of, the grants available. So we always make sure that patients are connected with social work, and we also have nurse navigators that make sure, if there is something going on with the patient, that their needs are met.
That's important. So you both mentioned social workers, and often patients don't realize that there are, people in place to actually sort of connect them to needed resources. So that's really wonderful information for everyone. I noticed that Grady is an NFL crucial cash site for lung cancer. What resources does the NFL Crucial Catch provide to the community? And the other question is, are there other resources at Grady to make it easier to get screened, diagnosed, and treated at Grady?
Yeah, so getting the ACS grant was very helpful. It was
Mhm,
actually allowed us to pay for a lot of our uninsured patients to get their screenings done. It also gave us more resources for a lot of transportation for screening because we had money allocated on the diagnosis end, but we didn't really have that money allocated on the screening portion. So a lot of the patients, would say that they don't have transportation funds. And before trying to scramble with social workers in primary care, trying to get money allocated. So actually this grant allowed us to allocate that money dedicated to getting patients to their screenings. And it also allowed us to hire a navigator to help me on the screening side that would
mhm.
actually do outreach calls to the patients. see if there's any reason why they're not scheduling. And a lot of time it is something like transportation or lack of funds, or they need help with scheduling. So having that extra person be able to do outreach calls is very helpful. So we actually have kept her on board. So that also showed us what's needed, and just having, extra support to do that one-on-one education with patients, making sure they understand what's going on. Because a lot of times just an extra call, will convince them, answer that one question they had burning that they were scared to ask the doctor when they were there. A lot of them, they get them ordered and they never schedule. So it's been helpful to have somebody else to call the patients.
It's always good to have that extra eyes and ears, that extra touch, right?
Yes.
So the question would be, do other hospitals have some similar resources? So I'll let Benet say a few words about that. And I might even weigh in a little bit myself about some resources. So go ahead, Benet.
I think it's amazing that the hospitals have extra resources. I too, just like Dana, received a assistant to help with calling the physicians, calling the patients, getting the patient scheduled. We also receive funds from the American Cancer Society, as well as some local charities that have given us funds. And we're in the process of doing a grant with Evans County, which is a community that's close to Savannah, but it's kind of like a few counties over on the outskirts, so that we can reach those patients as well. So those different grants and different funds that are flowing in definitely helps the patients get to their screenings. And it also, like Dana said, answers those unanswered questions. Like once you talk to them and let them know what the screening is about and how it can help them, then that kind of eases them a little bit so that they will come in and get screened. And having the extra set of hands, extra set of eyes and ears, and also the ability to call physician offices to get orders, and also to call the patient, remind and say, hey, you got a screening coming up, or hey, contact me if you need any help. That is a blessing, because it really goes right back into the community when we can get more people screened.
Absolutely. And I think that's a critical piece. I know at Northside, where I work, that we also have screening for lung cancer, et cetera. And we do have that patient assistance program. And like you guys, some additional funding to help patients get through this process. I think it takes everyone in the village to get that moving, right? Okay, so you both talked about the nurse navigator, and so I wanted to have a little bit more information for the audience to understand who the nurse navigators are and what their role is. So the first question goes to Dana. What is a nurse navigator, and how can I find a nurse navigator?
So the nurse navigator is like my best friend, because patients often hear from me on the pre-diagnosis end, because I'm calling them about their abnormal scan, getting them scheduled. We do have a lung nodule clinic, so the patients are usually coming to see myself and our Dr. Flonel, which is our interventional pulmonologist. So we're actually getting them scheduled for their biopsy. We see them for their results, and then once they have a diagnosis, I actually introduce them to the nurse navigator. So that navigator will actually take over with help scheduling the follow-up appointments, make sure they understand everything on the diagnosis end. So they make sure just patients comfortable through the process and understand what's going on. So they often, give them what their schedule look like, upcoming appointments, go over any chemo treatments, any treatment plans for them, and give them a direct number, because a lot of, patients that's their fear. You have cancer, and now, who can I talk to? So actually, that person that can actually help connect with their providers.
That's good. That's so important for the audience to know that this is available and what that role is. But I do know that there are many types of navigators. And so, Benet, if you can walk us through some of this. So we know that there are nurse navigators, social work navigators, patient navigators, even survivor navigators, or financial navigators. Can you help the audience to sort of understand a little bit about what some of those fine differences might be?
So in our system, we have a team of navigators. I actually work with the navigation team. And so I'm a diagnostic lung navigator. I handle all of the lung screenings. Once a patient is diagnosed, we do have a track navigator where we have a multidisciplinary clinic, and I can do any lung rats 3 or 4 to the track navigator, and she presents it to the multidisciplinary team. We also have actual lung navigator that if the patient does not go to track but actually has a diagnosis upon pathology, I send that patient directly to the lung navigator. And as Dana said, they coordinate appointments, they help the patient understand, they educate the patient, they educate the families, they do a lot of reassurance that they're going to be taken care of, and they basically just walk the walk with the patient. Now, they also, with the social workers that we have that sit with the navigation team, once a patient has been diagnosed with lung cancer and they may need palliative care or also see a medical oncologist or anything like that, the lung navigator and the social worker actually work hand in hand with taking care of their patients. So our navigation team consists of several nurse navigators, but we also have a track navigator, and I am the diagnostic lung navigator.
Do you, so Dana, do you guys have patient navigators or financial navigators at your institution?
Yeah, so I'll be on the diagnostic end, and then we have a nurse navigator, one that will help make sure the patient understands their treatment plan. Then we also have patient navigators. They're not clinical, but a lot of them are survivors. So they just help with extra calls, reassurance. Some patients come alone and they might need somebody to just sit with them. So they do different things that aren't clinical just to help assist with the journey that the patients have to go through, because some of them, they are alone in their journey.
Yeah. So that's really important for people to know also, that there are, different people on the team that really can, supplement and support them as they're waiting, number one, for answers, or as they need to go through the different stages of treatment, if indeed something's been discovered. So I thank you both for those answers, because I think that's so important, right? People don't know what's out there. It's already so scary. So it's important to know that these resources are available. So I want to shift the conversation a little bit to healthy lifestyle choices, because that also is a part of the preventive side of things as well. And so I know that we will want to be talking with patients about that. So I have a question that I'm going to direct to you, Benet. If I make healthy lifestyle choices, will you see improvement on my low-dose CT in the program?
I think healthy lifestyle choices promote overall health. Changes exactly from the CT. We have to remember that a lung screening CT is measuring tobacco smoke and the effects on the lungs. So although you make healthy life choices, that contributes more so to your overall health. And I don't think it specifically will show you a change or an effect on the actual lungs.
Okay. So, Dana, if I stop smoking, will lung nodules resolve or go away?
So to answer the question, it's actually yes and no.
Okay.
The majority of patients, when you do a CT scan for any reason, they are benign nodules that will probably sometimes never resolve. We don't know why they're there. Sometimes it's from all infection, just environmental things, but then also things like infections or inflammatory. Patients have different autoimmune disorders. Sometimes those nodules will resolve after whatever is going on has been taken care of, but some nodules will always be there. Some are scars, and then of course cancerous nodules. Our hope is that they will resolve after treatment.
So if I or a loved one quit smoking, what tobacco treatments would be available to me, and what would some of those, is there a cost for it? And I'll ask both of you to take a stab at it. We'll start with Benet.
Okay, so we have a medication management program where they actually will meet with a pharmacist and a physician. And when they meet with them, they'll determine the best process for tobacco cessation. And so what that entails is kind of like seeing what works best for the patient. I
Mhm.
personally, when I speak with the patient and navigating them before they have their lung screening, I talk to them about different routines and different methods that they can use to psychologically psych themselves out of smoking, such as replacing a cigarette with a straw or things like that,
Mhm.
so that they actually don't smoke. However, if they need assistance to the point to where they need to see a physician or they need tobacco cessation counseling, then we send them over to medication management, and they can do things like Chantix or nicotine gum or
Mhm.
patches or actual medicine that will help the patient to stop smoking.
That's great. I think, Dana, I want to ask you a question that's more of a follow-up to that. So I
Okay.
changed my mind about having you both answer that question. Is tobacco treatment counseling available in the evenings or weekends, by telephone, online, in person, groups? There's so many different ways, right? So if you could tell us if there's some availability of different modalities for one to get counseling for tobacco cessation.
Yeah, so our tobacco cessation groups, they're actually grouped. So it's up to 8 patients.
Hmm.
Never more than that. Usually they keep it about 4 just to help contain and actually have some good interaction with the patients.
Hmm.
It's 4 1-hour classes for the patient to be completed. A lot of times we actually have it established in our community clinics, so not just main Grady Hospital. So it's been helpful. We usually have behavioral health, different nurses that go through the training to actually help
Right.
facilitate those groups. So before COVID, we had different times, evenings, weekends.
Hmm.
So now we kind of streamlined it to now it's only at the main hospital right now.
Hmm.
During COVID, we try to implement telehealth for
Hmm.
the
Yeah.
session,
Yeah.
but patients weren't as open to it. It wasn't
Mm.
as good as the in-person interaction. So we
Yeah.
had it available, but we saw that the patient needed that one-on-one in-person time with, interacting with the other patients and the facilitator. So
Hmm.
we have it available, but a lot of patients, they don't want to utilize it.
Yeah. At Northside, we have the same. With COVID, we too, did the online, telehealth program, and we did get good, some good attendance. But I think that's overall what we're hearing. People really like that one-to-one interaction. But I think it's important for us to have, even after COVID, to have the availability still to have not just in person, but the online portal where they could do it, because not everyone might be able to do in person. And I think it's just good to have sort of like a variety of ways people can get that counseling, right?
Yep.
um, all right, so thank you. But now I want to talk a little bit about some barriers to care, because everything is wonderful. We have all these wonderful services available, transportation, all the team efforts, all the different times and days that people can have access, but there's still often barriers, right? So, Dana, could you talk to us about what you've seen, or maybe also in the literature, as barriers to lung cancer screening?
Biggest barrier is fear.
Mm-hmm.
Patients
Yeah.
just not understanding the process, and this is a screening that's tied, to death. When patients hear lung cancer, they think death.
Mm-hmm.
They think about lung cancer, they think about smoking. So there's this big stigma
Mm-hmm.
attached to lung cancer screening. So it makes it very difficult to actually, talk to the patients about screening, actually wanting them to have that conversation about smoking. So that's the biggest barrier that we see, like regardless of where it starts, the conversation, it's
Mm-hmm.
just that stigma attached to lung cancer and smoking. It makes it very, very, very difficult.
Mm-hmm. So, Benay, are there other things that you think we should be adding to the barriers list?
I think Dana pretty much covered it because of the stigma. It is that's I think fear and anxiety are the hugest barriers.
Mhm.
However, I personally feel like the current guidelines are a barrier because I know so many people that their spouse comes in for a lung screen and however they end up with lung cancer and the spouse does not. And so I feel like if a patient did not smoke and wanted to have a lung screening, they should still be able to do that. Even
Mhm.
though according to CMS guidelines, you have to be a current or former smoker. Well, what about secondhand smoke?
Second.
Or what about
Yeah.
carcinogenic careers like a painter or auto mechanic or somebody like that who would like to have a
Yeah.
screening done that did not smoke. So those are some of the current barriers that I would love to see CMS remove that criteria so that if a patient or any person that desires to have a lung screening can have one, no matter the age, no matter whether they smoked or not, or doesn't matter their career type. Just
Mhm.
across the board, if you would like to have a lung screening, you can have one.
Yeah. And that's the conversation we continue to have. I think
Mhm.
that's where advocacy comes in, right? So we also need to empower folks, that, they can begin to, talk to the people that make these laws, to address some of those things. Yeah, we talked about so many different components of this. I think it was really great. I really want to thank you both, Dana and Benay, for being here and just having that candid conversation with me around some of these issues, which I hope will be enlightening to our attendees at this event. And that they will feel a little bit more like they're armed with a little bit more in their arsenal, to sort of navigate a little bit. And if they know that if they cannot, that there are navigators and other people on the team that can help them to do that. So I really want to thank you for taking the time, being here with us and just talking about those important critical issues, to, sort of make preventive care one of the things that we have on the top shelf of the healthcare world. So I thank you. And it's what now we're going to turn our attention next to our patient care panel. We're going to have several patients that will come on and they'll talk to us about this important topic from a patient perspective, which is really great to have as well. Right? Thank you.
Good morning. Good morning. My name is Michelle Bolden, and I'm excited to host this patient panel. I'm the founder and CEO of Call for Caring, which is a nonprofit with a mission to support family caregivers through their journey. And so providing education and resources is a part of what we do and we enjoy most. So we're excited to be a part of this collaboration between many powerful organizations that are putting the word out about lung cancer. I'm excited to introduce our panel today. And so on our panel, we have Katina Bland, who was a caregiver. We have Terry Connerin, who is a patient, a cancer survivor, and Deborah Carpenter, also a survivor as well. So welcome you all to the panel. It's so good to see you.
Thank you.
Thank you.
Absolutely. Thank you. So I'm going to first start with kind of introducing yourself and tell a little bit about your personal journey or the one that the person you cared for in their personal journey, how it began with lung cancer. If you can kind of share if it was an early detection as well. So Katina, I'm going to ask you to go first in that beautiful background you have there.
Absolutely. Thank you so much, Michelle. I appreciate that. It is a privilege and a pleasure to be here on the panel with you, wonderful ladies. This is such an important topic. My beloved husband of nearly 20 years, Martel Blaine, I had the privilege of caring for and walking through just some of the most difficult times that we'd ever experienced in our life together. But my husband was a pillar of strength, not only for our four children, but in our community. He was a vibrant 49 years young, 6'4", healthy, strong, 220, gorgeous man who never smoked. He never smoked. He was a former collegiate athlete, pro athlete, successful executive in technology sales for decades. And so, you know, in the summer of 2020, our lives were impacted and rocked by more than COVID-19. But my husband was diagnosed with this silent killer. And I call it a silent killer because that's exactly, how it came to us without warning. Again, he was a non-smoker. He was healthy. Didn't fit the mold of what the stigma and society says a lung cancer patient should look like. And so it really, really took us by storm, which to me, I consider this disease to be a public health threat. And I say that because, again, the warning signs for him weren't glaring. It attacks sometimes the healthiest, strongest people. And as long as we continue to have that widespread misconception that what a typical lung patient with cancer looks like, we won't put ourselves in a position to arm ourselves to take preventative measures.
Absolutely. And was this an early detection? Talk a little bit about when you first found out about the diagnosis.
Yes, it was not an early detection. As a matter of fact, like I described, he was moving through life, coaching our children, being an athlete, very healthy, very conscientious about what he ate, how he took care of his body, and interestingly enough, still doing his annual doctor visits with his doctor to make sure he was well and healthy. We had our eyes on prostate because his grandfather and uncle had prostate, and that's the diagnosis that gets a lot of I suppose I'd say attention for men to
Yes.
look out for that, as well as women. Be on the lookout for breast cancer, but we don't pay attention to the fact that if, again, we do have lungs, we can get lung cancer. And so, no, when we received the tragic news and the diagnosis, he was in stage 4. He had some bone pain, back pain, that didn't really, we couldn't find the answer to it. Again, being an athlete, he tried physical therapy. We did a lot of things to try to troubleshoot, and he saw his doctor, and we couldn't find answers for several months. And when he went into the hospital and was tested, ran several blood tests and screenings and CT scans, that's when it was discovered. But it was discovered at stage 4.
Yes. Oh, that's powerful. Thank you for sharing that journey. And again, this is one of the reasons why we need to have this conversation, because as you said, it's a silent killer. And the silence is that we're not talking about it. And so this is great that we're having the conversation to let people know what they need to do to just screen and be aware. The best scenario here. And so we appreciate you for being here and sharing your family's journey. Deborah, I'm going to ask you to go next, introduce yourself and tell us about your journey, and even if early detection was a part of your journey.
I'm Deborah Carpenter. I'm a retired educator of 30 plus years. I am a cancer survivor and a KRAS patient advocate. I do want to start out by saying I smoked a half pack of cigarettes a day for 31 years. My mother died of lung cancer. I never smoked around her. My father died about 6 years later. It had nothing to do with cancer. But once I finished my father's estate, I wasn't sure what I wanted to do with my life. I wanted to make a change. At that time, I was tired of using the Nicorette smoke things to quit smoking, patches, gum, lozenges, Duke's smoking cessation clinic. I turned to God. On August 16th, 2014, I opened my Bible up to Philippians chapters. There's only 4 chapters. Verse 13 of chapter 4, I can do all things through Christ, which strengtheneth me. When I read that, I knew that I had hope, and I knew that I had a chance to make a difference, not only with my life, but with others. I did not have any early screening. I was probably one of those like Katina, like your husband, who was healthy. I appeared to be healthy. I was, walking a mile probably at a wellness center. I was doing yoga. I was doing silver sneakers. I was singing and walking at the silver sneakers group. Um, and I had even gotten a nutritionist. I worked with a personal trainer to improve. I did improve. My journey began in November of 2019. No screening. I just happened to exhibit some symptoms. My doctors thought that it was symptom of pneumonia. My ENT or allergist thought that it was symptoms of asthma. I received medication from both. It was neither. Once none of these things disappeared, the doctors recommended that I go to a pulmonologist, to a couple of other doctors. After several bronchoscopies, several different CT scans, I was diagnosed with lung cancer. My right lung, the lower right lobe, had to be resectioned, or I had a lobectomy. And my life changed from there. And it was much like a puzzle, in that we had different people trying to decide what's wrong, what's going on, what do we do. I was one of the fortunate ones to get involved in a clinical trial, specifically made for my cancer. It's KRAS G12C. Got the medication for that, began taking that. My oncologist called me the poof patient because it helped me to breathe in no time. You probably know, or some of you know, that with the clinical trials, you've got restrictions coming from the pharmaceutical company. So I ran into several roadblocks, or several different things that occurred where my liver enzymes were out of whack. And so it interrupted the taking of the clinical trial drug. Several things had occurred that I needed to work with to get going. With the clinical trial drugs and the liver enzymes, that can have some issues with diabetes, with the iron in your iron, how your body uses it, several different things. So I went through a lot of times of multiple pain medications, trying to find out what would work. My nurse, my research nurse with the medical team, actually told me more about the clinical trial drug. And of course, at first I said, no, I'm not going to be a guinea pig. The research nurse asked, so Deborah, what are you going to do? I had no answer, none. She said, you might want to really consider this clinical trial drug. It will give you hope, and it will give you a chance. And those two words have been my favorite words ever since. They give me life. They give me purpose. I have hope. I have a chance. And part of it has to do with me being here today and sharing with other people what I went through, my journey, the good, the bad, and the ugly. But I'm still here. So God has a purpose for me. And I like to talk, so I may have left out some of the answers that you had.
No, that was perfect. That was absolutely amazing. Thank you for sharing that journey, and hope and a chance. I mean, those are some words that will change my perspective as well. And just thank you for sharing that. The clinical trials are so important. I think we need to open our minds to that. And often as a community, we are very hesitant to open our minds to clinical trials. And so that may give you some opportunity, as you said, a hope and a chance to have a different outcome, a better outcome. Thank you for sharing that so much.
Thank you.
Terry, can you share about your journey? And was early detection a part of your journey?
No, it wasn't. First of all, let me just say good morning to everybody. And just following like Katina and Deborah, I mean, it's just so powerful to be here and be able to hear you guys. I'm Terry Conneran, and in January 2017, I was diagnosed with stage 3 lung cancer. What led up to that was I've been back and forth to the doctor, in and out, asthma, pneumonia. We thought it was hay fever. I'd had a backache for years, in and out and whatever. And it was just, I saw the PA. I didn't push. I didn't ask. And truth is, I used to have a smoking history. Okay. I used to do a lot of stuff, kind of like that bad boyfriend that you just kind of wish you could just like forget about, or that thing you stepped in and you wish you could just kind of move on. I had stopped smoking many years before, and so I didn't like qualify for the screening. But I was 55 years old by the time I was diagnosed. But looking back, okay, so now here's the benefit of looking back. Looking back, I can see that the backache that I'd had for 10 years, it wasn't like a cough. There wasn't these big movie moments. There was no coughing up blood. It was just kind of like, I was getting older. I was getting more out of shape. I wasn't as strong as I used to be. Summer bothered me more with the humidity, and humidity can be rough in the summer, but that's not what it was. So went to the doctor. And, just thinking I had, the typical cold that just wasn't going to go away. A couple days before Christmas, my husband's like, just go, get your antibiotics and move on. And I go into the doctor's office, and she can hear fluid in my lungs. She's like, oh, just pneumonia. Let's just do kind of like a basic chest x-ray. The pneumonia saved my life. The pneumonia fluid highlighted a tumor that was in my lungs. And we went in there, and she showed me this thing. Now, because everybody was clearing their desks right before Christmas, that was able to be read like right away. And you could see there was something there. She's like, well, we're going to put you on the antibiotics. We're going to do some inhaling treatments and what have you. Well, to kind of like speed up the story, come right back right after the first of the year, because nothing happens over the holidays other than you just feel lousy. Went back out to the pulmonologist, and the pulmonologist sent me for the bronchoscopy, and the bronchoscopy, which is scary. Because that they're going to go in and they're going to go down, and do whatever, and they take this biopsy. And from the biopsy, now I'm going to tell you, going through all of it, it feels like it's taking forever. But you're not going to get there, and you're not going to get the right answer unless you kind of keep pursuing it. And while you're going through it, that's why they call us a patient, because we have to be patient to keep going, right? And you've got to be able to be willing to show up. Anywhere in there, I could have just stopped. I had to keep going. And part of it is, and you start feeling poorly. Now, I know this is about screening, but let me just fast forward. So I went to the doctor in January. He did the bronchoscopy. He did a biopsy. And I ended up getting called on my daughter's 25th birthday and being told that I have lung cancer. Turned out to be stage 3. And the stage 3 lung cancer, because it was presented, we did some testing. They said, we need to wait to decide what is your best treatment. Waited a couple of weeks. They ended up saying there was nothing particularly there. So they cut out my lung. They cut out half my left lung. Went through some chemo. And a few months later, they said, okay, you have no evidence of disease. So I was stage 3 to no evidence of disease. Now they're doing it, but that didn't mean I just had to walk away. I had to keep going back to get scanned to make sure that everything's okay. Now, when scans are not that big of a deal. You just kind of like, you're in and out of there. And if I wear like yoga pants and like a yoga top, I don't even need to change my clothes. They just let me go in and out of that machine. I mean, like that's it. I'm longer to drive there. So it is. And so we went in, did the screening, did that. I kept watching it. So I had no evidence of disease for a year and a half. Then I had a first recurrence. Because we caught it, it was still small. We were able to treat it again. And I started learning in the lung cancer advocacy, we kind of break up these things called biomarkers. The biomarkers are the cancers that I'm just going to jump ahead if that's okay, Michelle. The biomarkers are what drive our cancer, okay? And there's different treatments based on your biomarker, okay, which is not an inherited thing. It's what's inside your body that's driving your cancer. And the doctors can give you the more details. Well, I learned that there's different types of biomarkers within our cancers, and we in the group get different treatments based on that. And so it tells you what is best. So I asked my doctor, what is my biomarker? She don't have a biomarker. Okay, first recurrence, still don't have a biomarker. Well, long story, after 3 years and 3 recurrences, I found out that I didn't have, in fact, have a biomarker, but I didn't find out until I went to the second opinion doctor. My second opinion doctor said, you have a biomarker. It was on your report. It was on your first report. It was on your second report, but your doctor wasn't telling you. Why wasn't my doctor telling me? I was asking the question, and I'm just going to call the obvious. I'm a white woman. I'm a middle-class woman asking the right questions, okay, and I'm not getting the answers. And I'm thinking, what about all the other people that are not getting the answers? And so I'm saying, like, if I have that going for me and I'm not getting the answers, which means I may not be getting the right treatment, what can I do? So I want to connect with other people that have this KRAS. Mine is a KRAS biomarker. That's how I know Deborah. I have a KRAS biomarker. And I started the KRAS kickers to kick cancer's KRAS because there's specific treatments that work for patients that have one biomarker over another. And I won't bore you with the other details of what they are. It doesn't matter, because what matters is if you get diagnosed, you can do something about it, right? I can't fix my car if I don't complain about it.
Right.
I can't fix my body if I don't know it's there. And Katina is 100% right. This is so silent. Okay.
Right.
I didn't have these big dramatic moments. Okay, but it was there. And so once I wanted to connect with other people, I started this organization, KRAS Kickers, so that I connect patients to the information, to the resources. So KRAS is more than just like the name of this biomarker, which is, I wanted to take it and turn it into something positive, because I believe hope shared is hope multiplied. Okay? And that's the only way it's going to grow, is by keep planting those seeds of hope. So KRAS, I don't want to have a negative part, even though it is kind of a fun thing to say as a KRAS kicker. Okay, but it's also, KRAS is also an acronym for KRAS knowledge, research, which means the resources, the advocacy, and the alliances for survivorship. And that takes the science. And so we bring that information together with the patients, because I am a patient. I want information, and I want us all to be able to share it.
Wow, Terry, thank you so much. And you just opened that door about the biomarkers as well. And so you talked about your journey with that, and also the advocacy you had to do for yourself from start until the end, right? And it's important that you mention about those who can't advocate for themselves are often those, sometimes us as a healthcare community. And I am a registered nurse, so I include myself sometimes being there, that we don't always hear or listen or suggest. And so you really do have to be an advocate for yourself. So Deborah, I'm going to ask you, did you have biomarkers? Did that play a role in your journey?
Yes, it did. The medical team actually sent my biopsy, whatever they had, to Foundation One. I did not have to ask. They did that immediately and told me what my genetic mutation was, the KRAS G12C, stage 4. And we actually began the clinical trials quickly. And the medication for the lung cancer that I had was provided for me free, because it was a university research hospital. So they immediately began taking care of me. And, even though I had, I actually had chemotherapy, I had the clinical trials, I had immunotherapy, several other things. When they actually added in the immunotherapy, that caused some problems for me, in that I lost the use of my right leg. But the immunotherapy caused my body to attack itself. But I was able to recover from that, because I'm a hard-headed woman. And I was going, just like Terry said, You can't just sit back and let things happen. You've got to empower yourself, and you've got to take control. But I had an excellent advocate with me, and that was my sister.
Awesome. Awesome. That's wonderful. And I'm guessing your sister was one of your caregivers as well?
Yes, ma'am.
Okay.
Yes.
Awesome. Wonderful. Wonderful.
She was there for all of the appointments. I guess whenever you hear that you have cancer, your ears just get clogged. You don't listen. She was a person who listened, took notes, asked questions, explained things for me, to me, pushed the doctor to do a variety of things, to answer questions. She was my lifeline.
Oh, yes.
And she's one of the reasons that I'm still here.
Oh, that's wonderful. Thank you. And thank you to your sister. Katina, I'm going to ask you, in our previous session, we talked a little bit about stigmas with lung cancer. Now, your husband's journey was really different. But there's still probably a stigma that he had to deal with regarding lung cancer. He was never really screened for it because it just wasn't something that would be part of something they would generally ask for because of his history. Can you talk a little bit about that? Is there a stigma that you had to deal with at all because of the diagnosis?
Absolutely. I remember the way that the diagnosis was actually, or the news of the diagnosis was delivered to my husband. It was done in a rather, let's just say, less than compassionate way. The delivery was very cavalier because we were troubleshooting, or many doctors were troubleshooting what may be wrong with him, and he was searching to find answers, and we were really persistent in asking questions that may have been, I suppose, maybe annoying or nagging to just probe and push. Where, I know there are some people who are often either intimidated or simply think, well, what the doctor says must be fact, it must be true. I won't push the envelope. Well, we are envelope pushers. And so in doing so, one of the doctors that were called in to rule out the possibility of something for my husband was a infectious disease doctor, because again, we were troubleshooting. And the doctor read a report and simply said to my husband, oh no, you don't have an infectious disease. It looks like you have cancer, you have lung cancer, and walked out the room and dropped that on my husband in the middle of quarantine where I couldn't physically be there with him. And he called me on the phone and expressed to me his doubt, his devastation, and his just disappointment. Really, with a medical professional being so cavalier with something that was so devastating, the way that he just dropped that information. And shortly after that, we were told that he had non-small cell lung cancer, which again was some medical vernacular that we'd never heard of. And we were thrust into this world of terms and acronyms and just medical terminology that we had never been exposed to. We weren't trained in, but we quickly hit the ground running and recognized we needed to understand, learn, and just be a quick study on what this means, what this world is, so that we can navigate through it. And a fellow friend and patient in the fight referred us to ICANN, which was the International Cancer and Advocacy Network. We met a Miss Marcia Horn, and her direction, her patient navigation, her expertise changed our life. She spent hours and hours and days and weeks on the phone with us. And even after my husband was offered the biomarker testing, we didn't understand how to read the report. We didn't understand what it meant. We didn't understand our mutation. We didn't understand our options. He did begin, like you, Deborah, chemotherapy regimen once we selected an oncologist. He did begin some immunotherapy, which was not successful. He did begin some radiation to help with the pain, but we still hadn't really heard mention of clinical trials, and that came later. And when I think about the time and the space of information being critical to every day that you learn something, your life can change. And it was several months down the line that we began a clinical trial for him, and once we did, it was life changing. It extended his life. He lived several months of beautiful, quality time with his family, feeling not like a cancer patient,
Right.
able to share his journey, make memories with his family, and give God glory for every day and every moment that he was given. And he was, one of the few that
Yeah.
hears about clinical trials, that qualifies for clinical trials, that
Right.
is bold enough and educated enough to actually pursue clinical trials without fear and intimidation and lack of knowledge and understanding. And so we did so. We had wonderful results, and we had an advocacy group, Exon 20 advocacy group, which is aligned with the ICANN network, that came alongside us whenever we hit a barrier or a wall or
Mm,
any type of um, just stumbling block that would
mm.
stop our pursuit of health and healing. They
Yes.
helped us to overcome that. And so my husband and I began a foundation, the Martell and Katina Bland Patient Education Program, so that we could educate and support others in their effort and in their fight to do the same. Because, like I said, Deborah and my husband Martell, and as well as Terry, we're a part of the few that have the opportunity to have made a difference in the choices we make to fight, to not lay down and say, well, I guess this is a death sentence, but to get up, pick ourselves up and say, well, let's go.
That's
What
right.
do we do now?
That's right.
And be an active part of your experience, of your healing, of your treatment with your medical professionals. It is not their job solely
Mm.
to lead you to make the decisions about your health, but you need to be an active participant in that journey.
Absolutely. And from each of you ladies, I've heard that your journey involved that. And I believe that's why you had the changes and the progress you did, because you advocated for yourself or there was someone advocating for you. There is not too many questions to answer. There is not a dumb question in the world. I always tell caregivers or families or patients to write your questions down. When you're at home and you think of something, write it down. So when you get to the doctor, you're ready for them. And they should be ready for you, because you are the most important part of your care plan is you were caring for, right? And so
That's right.
being an advocate for yourself, being persistent is just so important to your journey. And we're running out of time right now, but I want to give each of you all just a few seconds to identify who that person was who supported you and just tell them a thank you for doing that for you. So Deborah, I'm gonna go ahead and let you start first.
That was my sister. Um, I was very fortunate because she didn't work in the medical field, but she was one who would read research all the time.
Mm.
We had to go from one hospital to another to get a higher dosage of the clinical trial drug. So I thank God for my sister. I thank God for her persistence, her reading, her delving into things, to even being with me whenever we would go to the grocery store, and even letting me stay with her and her husband for a while too. She was the angel on my shoulder and my hope.
Yes, absolutely. Absolutely. Terry, I'll let you go ahead and say a few words for us
Okay.
about your advocate or caregiver.
It really does take a village. And I think my husband was my care partner. My kids were my motivation. My nurse navigator was my one of my biggest resources. And it's not just done because it's my lung cancer support community that really is like one of the best places to truly get that hope, that energy, and that like feet on the grounds, day to day information. And so, but it really is truthfully, God gets the glory is like really truly where really where it's really coming from. I'm just
Yes.
getting to see all the angels here on earth. And so, and it's an absolute privilege to be able to be here, be anywhere. And I just hope to use my voice to speak for those people that are unable to. and hopefully give back.
Thank you. Katina.
Oh my. I would say, firstly, my Lord and Savior Jesus Christ, and my mother Lorraine Carr, and my aunt Katie Cook, who gave up their life, sold their home, immediately moved to stay with my husband and I, to walk through this journey with us and be our left and right hand, to be there with our kids, to allow us to go on uh, appointments together and advocate together and fight together. They have been absolutely incredible. And Marsha Horn, with the AskICan.org organization, she armed us with the education that we needed to fight the fight and fight it well. So I'm indebted forever.
Well, I want to thank each of you for being here and sharing your amazing journey. And I know someone heard something today that's going to make a difference in their journey right now and just in their lives. And so thank you so much for sharing your journey. And we will have you a part of the Q&A session a little bit later. But now we're going to turn it over to our next presenter, Angela James from Longevity Spotlight. Angela?
Hello, everyone. Thank you so much for inviting me to this wonderful program today. The stories are just, my heart is in it. My name is Angela, and I am a care navigator and a social worker with the Longevity Foundation. Longevity is the nation's leading lung cancer nonprofit. We're changing outcomes for people with lung cancer through research, education, and support. Longevity's initiatives position us as thought leaders in the lung cancer advocacy community, providing programs and driving change for those with lung cancer today and in the future. People impacted by lung cancer can get help navigating their cancer from our website, which is www.longevity.org. Our lung cancer helpline, which is the number is 844-360-5864, and from survivors and caregiver mentors who have been where they are. We have peer-to-peer lifeline support program connecting lung cancer patients, survivors, and caregivers to mentors to get and give advice, encouragement, and hope. We have virtual patient Zoom meetups 4 times a week, multiple private patient and caregiver groups online, and provide multiple ways for people to get involved in the fight against lung cancer. We do have online groups for different oncogene types, such as EGFR, KRAS, ALK, no mutation, etc., as well as for those diagnosed with small cell lung cancer. We also host multiple in-person events across the country to educate and support patients at the community level. Also, currently, we are Longevity and the United States Federal Drug Administration. We're working together to learn more about how people impacted by lung cancer and their caregivers are living with the disease. This information can help guide lung cancer research and treatment in the future. Your voice does matter. We value your perspective. And the project that we're currently working on is called Project Peer. If you would like to participate in that and tell us your perspective from a lung cancer patient perspective as well as from a caregiver perspective, you will be compensated for your participation. At Longevity, we always want everyone to remember that anyone with lungs can get lung cancer. And we want patients, their caregivers, survivors, and their families to know they don't have to go through it alone. Please visit us at longevity.org or call our helpline. Again, it's 844-360-5864 to get connected. And thank you again for having me a part of this wonderful program.
Thank you. Great information. I'm sure those resources will be happy to many people. Thank you, Angela.
Very welcome. Thank you.
So now we're going to bring back on our patient panel as well as Dr. Flanall. and just address any additional questions that we may have. Welcome back, everyone. Thank you. Thank you. So I want to ask this first question to Dr. Flanall. As we discussed on the patient panel, we had some, experiences which involved, the screening wasn't done. They lived a normal, healthy life. How often should people be screened for lung cancer? What does the process look like? We've heard about the recommendations, and is it covered by insurance? Can you kind of address some of those questions, Dr. Flanall?
Yeah, so the recommendations are covered by insurance, Medicaid and Medicare. CMS has approved it. They're in the beginning, because we're still in the early stages of this screening process, so they're really tight on reimbursement for the screening. You have to stick within the recommended guidelines. Each institution is probably only allowed to deviate by about 10%, and that's right. So we're a little bit limited in that. One thing to keep in mind as we go through more of this, as we screen more people, we'll start to see differences. And the lung cancer screening guidelines will change. We've already seen a change where they lowered the age and they lowered the tobacco use history. And that was because they recognized that the first criteria was leaving out a lot of African Americans that were at risk. Mm-hmm. So stick with it, get screened. That data is being collected. And as we find different trends, that'll change.
Yeah. Thank you, Dr. Flanall. So I'm going to direct this next question to Benet. What do you think are some of the most important questions a patient should ask their provider when they're being diagnosed, screened, treated for lung cancer?
I personally think that a patient should ask any question that comes to mind, because no question is a dumb question. Mm-hmm. And with that being said, every patient is different, and every symptom I have seen, or even today have heard about lung screening and the diagnosis in lung cancer, can present itself differently depending on who it is. So any questions that a patient has going in, I just think they should ask even something as simple as Terry saying she had backache, or the thought of pneumonia, or just the different feelings and changes in your body. So any question, I feel personally, is a great question, not only for the physician, but for the navigator also to advocate for you if you're going in as a first time.
Absolutely. Thank you. And so, Katina, this question is for you. As you experience your journey with your husband, who or what do you think is the most important thing that a person living with lung cancer should have to help them in their way along their cancer journey?
I believe that needs to be someone who is there, someone who is present. I think going through this journey and fighting the fight alone, I think it can become overwhelming. Like Deborah was saying, you can be in the room with the doctor and you just can't hear what they're saying. The overwhelmment of emotion, the overwhelmment of, again, the newness of the information and what you need to do, and who's taking notes and who will remember what the doctor said are the next steps. You need to have someone, and if they can't physically be there, someone who can be on the phone or FaceTime, or you can record the information for them to dissect it for you and with you, and a resource that is just there to remind you why you're fighting. Because so often, we're going through the motions of another, session of chemo, and you're sick, and all of the different side effects that come from the treatment itself. Just having someone there to remind you, like Deborah said, there's hope. Our God sees you. He's with you in this, and to remind you, you are not alone. That is absolutely critical. Of course, the medical team is vital to your plan. They are kind of navigating the ship, if you will. But if you don't have someone there to simply encourage you, that this fight is worth fighting. This fight is worth winning. This fight, there's a reason to wake up and keep on keeping on.
Absolutely. And as Deborah shared, it's the hope
Yes.
and the chance, right? It's the hope and the
Yes.
chance. If nothing else, we lead with that to encourage us. And so, Deborah, can you share how your view of cancer changed since your diagnosis?
I'm not exactly sure how my view changed. But I do want to share with you that I do have a friend who said that lung cancer is an invisible disability. People don't see it. It's not like you've been in a battle in the war and you're missing a leg or any of that. It's an invisible disability that a lot of people just don't know about.
Mm-hmm.
But it's your reason to continue going. And as long as we have our brains, our heart, we can continue to gain knowledge and share knowledge. So that invisible disability, I'm ready to actually obliterate it, and we can all move on together.
That's right. Absolutely. And Dr. Flanell, we talked a little bit about biomarkers in our conversation as the patient panel and the importance of it. And Terry herself had to advocate repeatedly in order to get her biomarkers. How can we make biomarker status being known at diagnosis, part of disease progression, as just a standardized practice within the medical community?
I think in the medical community that it's starting to be recognized that that biomarkers, especially those that do have markers and can get treated, do have a significant survival benefit. And it's starting to get out that more and more testing is being done routinely. I think there's still a disparity in the number of African Americans that are being tested with biomarkers or offered biomarker testing than others. And one thing that can help is education, getting the word out, just like this program is right now, that there's communities that are at risk. If they come out down with lung cancer or found to have lung cancer, to ask those questions. This education is one of the most powerful tools we'll have. And things like this, getting it out to community, getting the word out. If you know somebody that's unfortunately diagnosed with lung cancer, remind them, ask about biomarkers, right? That's helpful. Go back and put them on them. And if there's a facility that doesn't offer it, you could consider looking to another facility that you may be a candidate for life-saving treatment.
Absolutely. And I think that's a good point to kind of end on, is about asking for it, being an advocate for yourself, and also repeatedly asking the question. And it's you never can ask too many times. You can get a second opinion if you need to. That's what Terry went as well. We just talked about so much today, to include the resources from our first panel that are out there that are able to support our cancer survivors, to the patient panel itself, which talks about the human portion of this, right? Because we have to remember, we are talking about people who have lives and loved ones who are part of their journey. And so I just want to thank each of you all so very much for the information that you provided, the uplift that you provided this audience, and hopefully the willingness for people to share, because we don't want this to be silence anymore. We want to continue to educate and take this out into the public so people can have outcomes that are much better than what we're seeing now. So again, thank you so much for being here. Thank you so much for being a part of this panel. And I'm going to turn it back over to Pastor Eddie.
Wow. Wow, 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 wow. I can't thank the panelists and our guests enough for all that you have done. This has been an amazing hour and a half. It doesn't seem like it's been that long, but it's been an hour and a half of robust conversations about lung cancer and its related illnesses. Oh my God, let me simply say, this is just the beginning. We have other resources and other workshops coming up. You certainly can visit the American Cancer Society, the Center for Disease control and prevention, and to decide who gets lung cancer, the NFL crucial catch, and cross kickers. I can go on and on and on and on, because this is an educational series that there's no way that we could have programmed this or planned this. And those individuals that you just heard of are living witnesses and testimonies of what God can do. Beloved, let me say this to you. As Katrina said earlier, you are not alone. The enemy would have us believe that we're in certain battles by ourselves, but the Bible says that there are war angels standing at the ready. And you've heard some war angels today. You've heard Dr. Christina and Dr. Eric and Dana and Brena. You've heard Michelle and Katrina and Terry and Deborah. And oh my God, some of the most amazing quotes. I got those quotes, and you know, preachers, we will steal your quote and put it in a message. So let me tell you, we have, again, some amazing things that are happening with us and through us through this collaborative effort. I thank God for Hill Collaborative, who has brought this to us, and we are educating the faith community about this most important issue. Amgen, Morehouse School of Medicine, Grady Healthcare System, Hill Collaborative again, Northside Hospital, Longevity, on and on. If I did not call your name, know that I am excited about what you're doing. Those who are with us today, please don't forget to fill out the post survey. We need that so we can hear your voice. Make a difference. The only thing that will allow evil to prevail in our world, you've heard it so many times, is for good men and women to do nothing. Don't sit back and do nothing. Do something. Fill out that survey, and we are coming right back to you again on August the 6th with our third installment of this community conversation on lung cancer. So I wouldn't miss it if I were you. Not only should you not miss it, but pass the word on. Tell somebody, post it. And this particular workshop here is going to be on Impact Church's website. You can visit us at www.impactdcd.org, and clips from this will be out there. I can't wait to get in the pulpit on tomorrow to let folks know, if you were not here, you missed it. And there are so many other things that we're going to be doing. I want to tell you something. We're going to have the one of our sessions, our workshops, is going to be live on the campus of Impact Church. We're preparing the radio live presentation. And so if you are in the Atlanta area, or you know someone in the Atlanta area that can benefit from this, please do not wait. Don't wait. Don't wait. Don't wait. Click on that QR code and register now for the August 6th workshop number 3 and the September workshop number 4, which will be our last workshop in this series. But we have so many things. I'm talking real fast because I know we're out of time, and I'm exploding inside with this information. Thank you all again. Thank you to our presenters. Thank you to our sponsors. Thank you to the participants who took out time from your holiday weekend to be with us. And with that said, will you bow with me in prayer for a last word unto our Father? Father, we thank you again for what our eyes have seen, our ears have heard, what our hearts have experienced. Thank you for the testimony of these mighty men and women. Thank you for the information that was given and the education that was laid out before us. Now, God, help us to put feet to our faith and go out and make a difference in the world. Protect us and keep us until we arrive here again. This is our prayer in Christ Jesus' name. And all those that agree say amen, amen, amen. I look forward to seeing you. Don't lie to me now. Log on, register, and be prepared for August the 6th for another amazing workshop, because we're doing it, and we're doing it all for the glory of God. Love you guys. See you very soon. Bye-bye.